I'm now going to hand over to Kat DeBacker and Erica Hayhill again. Erica's our star pupil today, and they're going to be talking about the Mums at Risk study, which is looking at, oh, I'm on the wrong notes again, I've got my wrong glasses. Here we go. Presenting the findings, funded again by the NIHR, that I can never say, through a doctoral research fellowship and led by Kat. And Erica was involved from the very start in the research as part of the advisory panel, because the whole project was advised by women with lived experience. So over to you guys.
Thank you. So good morning, and thank you all for joining us. To me personally, this is a very special day. It's not just a conference. For me, this is 3 years in the making. It's the end of my PhD, and this is sort of the cherry on the cake, and share findings from 3 years of quite hard work. And you've met the advisory panel. They're involved in lots of different projects, but I had the privilege to work with all of the 5 women that you've met before. And if you can imagine 20 minutes with them on a stage, how impressive that is. Imagine 3 years of regular meetings that took 2 hours every time. You can imagine how they've shaped my thinking, and they have just been my absolute guiding light throughout the last 3 years. So I can't be more grateful. As Erica said, she said, involve me. I took that very literally. So I should write it on here today with me. Together we've spent the last few months, we've spent quite a lot of time working with Tonka's over there to actually capture some of the findings from the research in something that was engaging, powerful, and easy to access, rather than graphs, and sorry, graphs. We have a few of those as well. But so we are using these illustrations, and you probably have seen them in the coffee room as well. And do grab a copy of the summary report. Again, aims to be accessible. Take it back to your service managers, to your colleagues. Talk you through the key findings from our work. And so the motivation to do this research for me was triggered by my own clinical experience. I'm a midwife. And I witnessed separation between mothers and newborn babies on the postnatal ward, and the distress that caused, obviously to that woman and her baby, but also to the professionals. I don't think there's any professional that enjoys that process, that wants to be a part of it. And as a midwife myself, I felt really out of my depth to support these women through such a horrific time, and to make that horrible event slightly less because of the amazing work of people in the room. But that was the driving factor. So I applied for some money to do this piece of research. And basically what I've done is I've done a systematic review looking at all the qualitative evidence that had been published already about people's healthcare experiences, either providing healthcare or accessing healthcare when there's child protection processes rumbling on. We did a cohort study of the Elixir Born in South London database of pregnancy records, and those are linked with mental health records in South London, and that allowed us to explore who has contact with social services during pregnancy and for what reasons. I also did interviews with women with lived experience of infant removal to explore their expectations, their care needs, and their recommendations in that context. And we also completed a cohort study and confidential inquiry using Embrace UK data of all the women who had died in the UK since 2014 up to 2022, and who had children's social care involvement prior to their death. And that was in pregnancy or in the year after pregnancy. And all of those results were quite sort of overwhelming, but we tried to merge them through some stakeholder sessions with a range of professionals from maternity, mental health services, third sector social care, leading to our summary report, which you can find in the room next door. But all along, these amazing women have been involved, literally from conception to the very end. So what are our findings?
So the past does not stay in the past. To begin with, we noticed that the past does not stay in the past. Among the different cohorts, childhood adversity was common, and the impact of this rippled on through women's adult life, either in their interpersonal relationships or the coping strategies they turned to. From the different studies, it was clear that previous contact with children's social care sets women up for a cycle of involvement with them, either because they were in care themselves or because they had contact with older children. For example, half of the women who took part in the interviews grew up in the care system themselves. This is a red flag to be referred when they themselves became pregnant. Previous contact for older children had a similar effect and was evidence in the confidential inquiry. Of the 47 women whose case notes were examined in detail, 36 of those were multiporous women and 2/3 had their older children not in their care.
And when we go back and looking at some findings in more detail, this is a graph from the Elixir Born in South London study that we did. And you can see all the risk factors from local guidance about what constitutes a referral indication in pregnancy, and the black dots are the relative risks, so they give you a likelihood of to be referred. And you can see the ones furthest to the right side, so the more the ones with the highest risk of having children's social care involvement are actually the ones that are related to previous contact, either because a mother was a care leaver or because previous children of her were removed or adopted.
So we've seen from all the different studies that women with children's social care involvement present with complex and cumulative adversity such as poverty, insecure finances, housing issues, limited social support, domestic abuse, learning difficulties and disabilities, being a recent migrant to the UK, substance use, contact with the criminal justice system and many other things. But women also often had medical complexity, either because they had pre-existing medical diagnoses or pregnancy-related risk factors. And these interact with one another and make for a really, really challenging balancing act for women.
So if we take it to the two different cohorts of women that we studied, the first one is that pregnancy cohort in South London, and it's an area known for its ethnic and socioeconomic diversity. The second one is the Embrace cohort of all the women who died between 2014 and 2022. And the first number is the group of women who had children's social care involvement as part of that bigger cohort. The second number is the women in that cohort who didn't have children's social care involvement. So when we compared these two groups in each of the cohorts, we found significant differences for pre-existing medical problems, and you can see the differences in percentages for each of the studies. There were significant differences for mental health problems between the two groups and obstetric problems, but also certain obstetric risk factors, for instance, smoking during pregnancy. And while these were just a few of the variables that we studied, they give you an idea of the high level of medical, obstetric, and psychiatric vulnerability and complexity that then impacts women's pregnancy journeys and antenatal follow-up. And this is what an antenatal care pathway can look like. This is taken from an actual woman's case note that was included in the confidential inquiry. And for every layer of that onion, there's a professional involvement, and the black dots are the point of contact with that professional agency or person. And because of this particular woman's medical and social complexity, a range of professionals became involved across a range of different services. And her antenatal appointment schedule became more and more crowded as her pregnancy progressed, making it more and more difficult to keep up with a very challenging schedule of appointments. And when she missed 3 appointments, and those are the ones, the red dots, there was very reductive, from that point onwards, there was very reductive and stigmatizing labelling found in her notes, which said poor tender, which was copied time and time and time again, even during an interpartum care episode at every shift change. And it completely disregarded the overall efforts that this woman had undertaken amidst all of the things she was juggling to keep up with antenatal appointment schedules that are just really, really hard for anyone, but let alone if you've got so many things on your plate. Of maternal deaths amongst all the women that have died in the UK since 2014. And this is the proportion of women with children's social care involvement since 2014. You can see a peak there in 2019-2021, which sits at 34%. But just like Katie mentioned, 1/3 overall in that 8-year window, 1/3 of all the women in the UK who die during pregnancy or the year after had children's social care involvement, and that is a lot higher because we have included late maternal deaths, and you can see that actually is the time period when most of these women unfortunately die, and that's the blue bars.
So then the issue of domestic abuse, it's very common, but the professional focus is directed towards the baby. So across the different studies, prevalence of domestic abuse was high. In the Embrace UK cohort study, 65% of women who died with CSC involvement reported domestic abuse, compared to 3% among women who did not have CSC prior to their death. We have to bear in mind that domestic abuse in both groups are likely to be underreported. From the confidential inquiry, we found very limited evidence of routine investigation, even when signs of domestic abuse or assault injuries were obvious, or when reports had been shared with maternity services by police or social care. Professional curiosity asking about women's circumstances at home was often missing, resulting in limited signposting to domestic abuse support services. Professional focus was directed towards the baby and not towards treating women's own safeguarding needs on the same par. It also meant professionals were underestimating the profound impact of domestic abuse on the women's confidence and their ability to access the services that they needed. And also we found that, the system is complex. People are trying to navigate a multi-agency system. So pregnancy journeys are complex in themselves for women, for all the reasons we shared before. And it's further complicated by the challenges in navigating multi-agency systems, each with their own expectations, thresholds, communications, and plans. It was clear from the confidential inquiry that this was not only confusing to women, but also to professionals who were unsure about processes with information systems that weren't compatible. This created system barriers, making it even harder for women who had their own individual deterrents to access and engage with this complex apparatus. So this idea that judgment and stigma, we touched on it before, are detrimental. So professional judgment and stigma was evident, both from what the women shared in interviews and from what we found in the confidential inquiry. This included the documentation in clinical notes using reductive and negative labels, stripping women of their individuality, referencing previous behaviours when there was no clinical need to do so, or phrases that reflect an absence of trauma-informed approach to understanding adverse life events. Ethnic and socio-economic disparities were found in both the cohorts we studied, with women from the most deprived areas being overrepresented in both. In the South London cohort, we found that the pregnant people from Black and mixed ethnic groups were more likely to be in contact with their children's social care. However, national data of all the women who died showed that CSE involvement were more likely to be white, those that died. And I think this is really important to emphasise that post-separation support for mothers is crucial. We could see from the inquiry and interviews that women who went on to have their baby removed had no post-separation support. Few women received enhanced postnatal midwifery care, and some were discharged from maternity services after a single visit or even just a phone call. Women struggled to access sustained mental health support, which meant their point of crisis many turned to A&E as a last resort. From reviewing their medical records, A&E staff did not fully comprehend or understand the context of these women's suicide attempts, so they missed opportunities to put in real support.
And when we looked at the South London the Alexis born in South London cohort, we investigated differences in mental health service utilisation for women with contact with children's social care during pregnancy. That's the blue group, and compare them to those without any contact, and that's the orange group. And we looked at 3 different time points prior to conception, during pregnancy, or in the year after giving birth. Of the total cohort, there was 5,000 women who had a record in secondary mental health services, and about a quarter of them had children's social care involvement. But when you looked at when these women were able to access support, the women with children's social care involvement were using secondary mental health services much earlier in life, had a lot higher uptake of child-adolescent mental health services, not just in sort of frequency of contact, but also in duration of contact. And that is sort of an indication of already sort of mental health needs arising at a very young age. And I think that is what Sally was sort of mentioning in her sort of introductory talk. what we see, unfortunately, is in the postnatal period, and this is not just for women who had the baby removed, but anyone who had children's social care involvement during pregnancy, is that access to mental health services all of a sudden become a lot harder for these women. And the differences between the two groups, where they were significant before, significant differences prior to conception, during pregnancy, became insignificant, and that indicates struggles of these women to be eligible for sustained postnatal mental health support and services that they need.
But of course, it's not all negative. We can't always focus on the bad stuff. So we found that trauma-informed, person-centred care can save lives. So throughout this work, we've seen and heard high-quality, exemplary care where professionals rallied together and advocated for women and their families. Women shared in interviews how kindness and compassion made them feel seen, heard and supported, and this seems to have come up quite a bit, doesn't it? And that can be life-saving. So like Demi so beautifully said, one of the people that was interviewed, when you're being judged left, right and centre and you feel so down on yourself, that one little piece of kindness can be what stops you from getting worse. If I had been treated like a villain in the hospital, like I was by everybody else, I would have left the hospital alone with no baby that night, and I wouldn't be here now. They literally were the ones that saved me. If they had not treated me like that, I wouldn't have thought I was going to be enough to live.
So, on that very powerful note, if you want to read more, so pick up a copy of the summary report in the room next door. This is a QR code to the Embrace work, which was only published Friday, very timely for this conference. And some other sort of strands of the study that have made it to publication so far. And then all that leaves me, I don't want to sort of take this slide down while you're scanning your QR code. This, while it was sort of my PhD, it's been a huge collaborative effort for so many people involved. A lot of you are in the room. My primary supervisor, Abby Dale Easter, is sitting right in front of me, keeping me to time. She's been phenomenal, as so many other people. But in particularly my guiding lights through the last 3 years. So thank you all. I'm having a
break for lunch later. Welcome back to everybody in the room. I do hope that you managed to find your toilets and your snacks. I can't say anything about your quality of snacks, but we were very well looked after, so I hope you were too. So let's get cracking. I'm going to now hand over to Kirsty Kitchen, Head of Policy at Birth Companions, to take us through the policy picture. Kirsty, over to you.
That was a quicker introduction than I was. Thank you. Hi everyone. I hope you've had a moment to just let some of this morning settle as well, because that is a lot. And we did talk at length about what this conference was going to focus on, and we did settle on hearts and minds, and I think we've set the hearts and minds racing. Mine certainly are. So thank you to everyone who spoke this morning. I'm going to try not to make this as dry as it suggests on the slide by talking about policy after all of that. But I think it's really, really crucial, because to summarise this morning's conversations, really we're all here because we want to be part of that change. We want to improve things, move things along, and we want to do that for all of the reasons that have been discussed. Because there's huge rates of infant removal, because there's very high rates of urgent and sometimes virtually immediate hearings, because there are many women dying, unfortunately, every year who are known to children's social care, and that we now know that number is higher than we had previously had in our minds. And we're here because of that postcode lottery that Brooklyn talked about as well, because there is such regional variation across the country, and that's just not right. So that's where policy comes in, really. We know some of us are part of delivering it. Many of us get to witness it. We know that there is excellent provision in pockets around the country. And we know that it's just a travesty that not everyone gets to benefit from that provision yet, that it's not consistent, and that it's not available to all. And so policy can work with provision to fix that. as Isabel said this morning, the government, not just on social care but on health as well, has made some really positive commitments in this space. The sort of visions to keep families safely together, to break down the barriers to opportunity, in the NHS 10-year plan and across the health space, a shift to prevention, public health models of support closer to where people are in their communities, addressing their needs holistically. These are all really, really positive things that have been matched to some degree with some money in the comprehensive spending review, some areas better than others. And also that there is this really strong commitment to cross-departmental working, and that's where things have fallen down for so long, that the solutions to very complex problems have been, if they are being considered, have been considered from one part of the picture and with one part of a funding pot that doesn't actually allow us to engage with the reality of things. So there is some positive policy opportunity for us, and we have to seize it. But we have really got our work cut out for us, because what we need to make a difference in this space is we need to embed the experiences, the lives, the challenges of mothers and babies who have children's social care involvement in this really fundamental first 1,001 days from conception to a child's second birthday, in every single policy space that has an impact on their lives. And there are many gaps for us to fill in terms of that. So we've touched on it already this morning. Perinatal mental health provision. You know, if you do qualify for that, and that's a high bar to reach, if your baby is removed in virtually every part of the country at the moment, that perinatal mental health support will be taken away from you instantly, and you'll be rerouted onto adult generic mental health waiting lists. That's one policy area of a huge list. I haven't put them all up here yet, but we've got to address that. Maternal mental health services were created to, serve the lower threshold needs of women, and the vision was to include a pathway for women who experience trauma through loss via removal. And yet, very few of those pathways are up and running around the country. The ones that are really struggling in terms of resources, that's another policy space that we've got to do more work on. The only bit of nice guidance that should really already house reference to these women and families, nice CG 110, complex social factors in pregnancy, makes no reference to them whatsoever. So we've got to close these gaps if we're really going to be in a position to create the sort of culture, the service, the system environment to do things differently for women. We're going to talk in one of the breakout sessions later, that I can't be in because I'm doing another one, about trauma-informed family courts. If we can look at health and social care spaces, but we ignore the way that the family court system works, we're only going to be shifting some of these harms into different spaces. And I won't even risk getting started on women's dual contact with criminal justice and the family justice systems, but that is a massive area that we need to think about, as well as ending the intergenerational cycles of care involvement that Kat's work has shone such a light on. So we need this in all policies approach. Sometimes people talk about health in all policies as a way forward to address complex health needs and the social determinants of health. We need, but I didn't want to write it down because it's ridiculously long, children's social care in the first 1,001 days in all policies approach to make some real change in this area. That's why, as well as doing the work that we do and supporting the work that many others are doing to fill those policy gaps, to create change in those specific spaces, that is also why at Birth Companions we're really excited and very proud to be leading a new piece of work to develop a joint national health and social care pathway, so that we can guide some fundamentally different work across all of those policy areas, but from a national level. There is so much being done regionally, locally, and that's right, that things should work from the ground up, but we need much more coming down from the national level to support all of this. The health and social care pathway, you will hear us going on about relentlessly from here on in. Across the next 18 months. It's something that we're co-designing in partnership with an amazing bunch of people with lived and learned experience, but we're also going to be coming out to wider stakeholders through a call for evidence, through a whole series of co-design meetings later this year. So you will be bombarded probably by me with requests to feed into this. But fundamentally, what it's about is creating that consistent, coordinated and compassionate set of systems, not just one system, not just one part of one system, but all of these systems working in this way, consistently, coordinated and compassionately with women. Our National Advisory Group met for the first time, very kindly hosted by Isabel Trowler at the Department for Education, just over a month ago. And we're going to sort of steer this with many of the people in this room across the next 18 months to create a preliminary pathway that we can test out, develop and then embed across the country. It's loosely modelled, inspired by, for those of you working in the health space, the National Bereavement Care Pathway that has been really transformative in maternity systems and is now in every local trust across England and moving into Scotland. So there's really good precedent for this work. As I've said, we're going to basically synthesize all of the amazing guidance that's out there, the research, the insight, the lived experience, testimony, the sort of hard-won learnings and teachings, bring it all together and hopefully establish what will be a national standard for everyone to work to and be guided by, supported with tools and resources. And we would love, those of you joining my breakout discussion later, would love to kick off some of that thinking with you today. The pathway won't fix everything on its own terms. What it's there to do, though, is to lead the conversation and then also tell us a little bit more about the things that maybe do need to change at national policy level in order to support that kind of care. But before I wrap up and hand over to an amazing panel of speakers, I just wanted to end on some reflections on complexity. I promise you I did write this before today. I haven't just added this slide in because everyone's gone on about complexity so much, but I did know it would come up. And I knew it would come up because it is in every single review, every single study, every single resource, every single serious case review. The theme of complexity is so strong. And what we know is that systems deliberately design out complexity. That's what they do. That's what makes a system work, unless it's told to do otherwise. And actually, what we've got to do moving forwards is to make sure that our systems, our services, our bits of the system can engage with that complexity, that real humanity that makes life so beautiful and so messy and so difficult, but also so rewarding. And personally for me, but I know for many others in this room as well, that's where we see the National Care Pathway really making a difference. Because if we can guide systems and services to be able to confidently engage with complexity and work with other parts of complex systems and services, then I think we can unlock a chance to work in a fundamentally different way, one that's led by compassion, empathy, that creates space for trust in what will always be incredibly difficult services and systems. So I hope that is an inspiring take on the policy and not something that brings us back down to earth with a bump. Thank you.
Thank you, Kirsty, and I apologise. I'm literally rattling through the speakers and pushing everybody on so that we can get going as quickly as possible. We're now going to hear from a panel of speakers who I'm going to invite to join me on the stage, and we are going to play the videos while they're actually taking their seats, because we're trying to manage time as best we can. So we have Phoebe White from Project Unity, a project to break the cycle of care involvement as part of the National Youth Advocacy Service in Wales. We have Kay Everard, Service Manager at Sheffield City Council, where they're implementing an integrated pre-birth care pathway. Pauline Bigglesworth from Blackpool Council's Health Determinants Research Collaboration. Well, that's a mouthful.
I get to say nearly every day.
She's going to share her expertise on co-designing with parents, and then to my wonderful colleagues, to Kate Chivers, Head of Engagement at Birth Companions, but also part of Project Giving Hope, and also joined by Pauline and Brooklyn, two of our amazing Hope mums who are going to join the stage as well. And then you will see a QR code. This is our wonderful Mentimeter. So you should be able to take a picture. It will take you onto the site where you can then pose any questions that you may have for our panel members. Don't worry if you can't get it to work. We do also have a roving mic as well. I'm hoping someone else is going to be doing the roving and I will just be doing the questions. That's good to know. So we're going to play some videos first to give you an idea about the project, and then we're going to have a discussion. So.
A holistaidd ar gyfer bobl ifanc a mamau ifanc a mamau beichiog oedd efo profiad o fod mewn gofal. Mae'r gwahaniaeth yn ei wneud yn enfawr. Yn aml iawn, maen nhw jyst angen y cymorth yna, rwy'n yn gefn iddyn nhw, rwy'n yn gymorth iddyn nhw, mwyn arwain nhw ar y ffordd i sicrhau bod nhw yn gwybod eu hawliau, bod nhw'n gwybod yr wybodaeth i gyd yn glir, a wedi bod nhw'n medru wneud penderfyniadau yn seiliedig ar y wybodaeth hynny.
We've had help with housing, which has been brilliant, and also we've had help with feeling confident. It's very important because you have got young mothers out there, and it's nice to have someone out there that will help you and that will support you and just listen to you.
So as you can see, that was Project Unity, and we're now going to share a clip from Sheffield City Council.
We're improving perinatal support for parents who are at risk of having their children removed at birth. And this is part of the Start for Life Parents and Infant Mental Health Programme. These parents often get very little emotional support during what is an incredibly distressing period of their lives. And that can have a big impact on both the parent and the infant's mental health. So we're working as part of a multi-agency partnership to improve the whole care pathway and make sure that the experience that parents receive is trauma reducing. So we plan to make a podcast for any staff who are working with parents during this difficult time, to make the training more accessible and to give them an opportunity to learn all about the new care pathway.
We are working with our midwife colleagues to find confidential spaces for parents to have difficult conversations with social workers following birth. We want to provide a laptop to the hospital so that parents can attend court virtually if they prefer, rather than leaving their baby in hospital. We have created a Place Elsewhere plan which parents can complete with social workers, parents and family and friends following birth. This helps give positive choice to parents on things like skin-to-skin contact, memory making and who can be with them in hospital to support them. Fresh Start work with parents who have had their children accommodated by the local authority to address loss, build resilience and make positive lifelong changes.
Fresh Start has given me volunteering opportunities to help encourage women that have been in similar situations that I've been in previously. Yeah, it's been a fantastic opportunity to give hope to others that have none.
In Sheffield Family Hubs, we're committed to supporting those people whose babies are placed elsewhere to breastfeed if they want to. We also have doula volunteers who can support pre and postnatally as part of the pre-birth plan. We've got infant feeding peer support workers who could be linked into the plan to support birthing people to understand their feeding choices. And we also have a breast pump learn service to support those people who would like to express them this way.
We've been looking at what parents need when they leave hospital, supporting with maternity, clothes, food, ways of getting home, and to ensure that they have enough things for a shower. We have developed our Cared What Elsewhere form to help limit the number of times parents tell their story and to help reduce the number of unnecessary challenges that they face, including around housing and benefits. We have looked at the long-term support needs of our parents and who can offer this support.
Oh no, I'm sure you've done this on purpose, so I'll have to say this thing again that I couldn't say the first time round. We've now got Blackpool Council's Health Determinants Research Collaboration.
There won't be a day goes by until my baby turns 18 and that I'm not scared of someone coming knocking on my door.
Parents can change. Everybody has capacity to change.
I went home some weeks and cried, I'll be honest.
Often there's the fear from social workers that they need to get things right.
You are like a deer in the headlights. You stood there not knowing which way to go, what to do, and you come face to face with a challenge.
A lot of the recommendations are around just seeing people as humans and giving time and respect and building relationships.
I found the process absolutely amazing, really. And I've already begun to implement some of the things that I learned in that group in our processes and decision making. It can only get better.
The co-production process has helped quite a lot of us. The other women and stuff seem to be a lot more confident and vocal about what they're saying. And I think professionals are wanting to be more understanding of what parents are going through. If we can all come together and speak openly, then we can move forward together, can't we, rather than against each other.
Knowing there's going to be an end goal for this co-production is very, I would say, exhilarating almost. That's like a relief again, knowing it'll help others, hopefully change the system, and there are already changes.
And I think that's probably the biggest thing that I'll take away from it all is I've learned a hell of a lot about myself.
I keep trying to sort of take a step back and think to myself, right, things will change. We've got this, we're going to make a real difference.
Each and every one of us have taken something away from this that will help us to change our practice and hopefully change the experiences of children and families in Blackpool in the future.
And our final video will be on our Giving Hope project. Each year, more than 3,000 mothers in England are separated from their newborn babies due to safeguarding concerns. They are often given very little notice, with the initial court hearing that will determine their baby's future being held within days or even hours of giving birth. Their worlds are turned completely upside down. If the judge orders an initial separation, the baby is temporarily placed into someone else's care. The court will later make a final decision where the baby should live long term. This process will likely take 6 months. The mother is left overwhelmed with feelings of emptiness, anger, and shame. A mother usually sees her baby for an hour at a time, organised by the local authority. While trying to find their feet, mothers are left managing grief, loss, and stigma. It is lonely. The Hope Boxes help them to feel connected to their baby and still feel like a mother. Each Hope Box contains carefully chosen items to support a mother with grief, emptiness, anger, and shame. A baby book, shared with the baby's carer, helps the mother feel part of her baby's day-to-day life. She is comforted by a glance at memories and firsts she may otherwise have missed. Both mother and baby have a blanket that is swapped at family time. The mother's smell comforts her baby and helps them to settle in their new surroundings. The smell of her baby allows the mother to feel connected. The Hope Boxes have been created by a group of mothers who understand the pain of separation. They send a message of hope. Hold on, pain eases. The Hope Boxes help mothers through this dark time with items that provide comfort and connect them to their babies. This connection will be crucial if they are separated long term. The Child's Hope Box will, as they grow, help the child understand their identity and to know they have always been loved. Separation between mothers and babies happens for varied reasons and with different outcomes. Mothers often feel labelled rather than supported. There is a lack of understanding of the trauma and challenges that mothers face. The Hope Boxes can help build a bridge of understanding and transform stigma and isolation into solidarity and support. There are thousands of mothers and babies who could benefit from the Hope Boxes. For more information, please visit the Giving Hope website and find out how you can help. And for those of you paying attention, you may have recognised a voice in the background of that animation, so I tend to pop up. And I'm just going to position myself around here because I realise otherwise I'm expecting everybody on the panel to turn their heads. So if it means I turn my back on some of you, I apologise. I'm going to be addressing these very important people. So I'm going to come to you each in turn, and for the purposes of easing confusion, there's going to be a Pauline Hope and a Pauline Blackpool, because then otherwise I'm going to get myself completely confused as to who I'm speaking to first. So Phoebe, I'm going to come to you first, and I'm going to say, what was the most important learning that you found in setting up your project or offer?
So Project Unity works exclusively with care experience, young women and girls, and what we found from the work that we do with these women is that the early intervention is really important. These are women who, as children, have been taken into a system, and then the fact that a decision was made for them to be in the system is then being used as the reason for why they're then deemed to not be able to safely parent their own children. So that early intervention needs to start at the point of when they, as children, enter the system. They need to be able to access kind of compassionate, empathetic and trauma-informed support, and having that early intervention, so then when they do go on to become mothers, they've got the tools and the support there to safely parent their children and also look after themselves at the same time as well. So yeah, the early intervention is what we found to be the most important.
Brilliant. And it's that thing of, you know, for us, some of us were judged for choices and decisions we made, and in this instance they're being judged for choices and decisions they had absolutely no control over, and therefore it's important we see them as individuals worthy of support and not just a label. Brilliant, thank you. So I'm going to come to Kay next with the same question as to what were the most important learnings that you took away from setting up?
I think one of them is probably how much is out there. So it wasn't until we sat down with midwife colleagues and some of the third sector charities that we already knew that we then figured out how much was available for mums and babies that wasn't being used necessarily because people didn't know to refer to them. So I think that was really interesting, how in the first few months the group just grew and grew to this massive number of services that we have. And then figuring out a service plan of at what point antenatally people can be referred in, at what point they will drop off. So that thing about all the services following mum was really stark from the work that we did with just a key 2 or 3 that stay with mum. So then it was about negotiating with services as to how long after birth could they stay. So we've managed to get our perinatal mental health team to work with mums for 4 weeks after birth to try and transition them better, which is something. It's not everything, but it's a start. So I think how much is there, especially for social workers. You might not necessarily be in early help, you might not necessarily be in the communities as much as your early help colleagues or your community midwife colleagues. So it's that directory of what you can refer mums onto so that they have support.
Yeah, absolutely. And I think it goes back to that, what we've been saying all day about the importance of listening to those with lived experience in those communities, because they, again, signpost you to resources that you may not have noticed, and seeing them themselves as a resource rather than just relying on all of the practitioners to come up with the solutions. The solutions are often there in the community. So it's about finding them. So that's brilliant. So now I'm going to come to Pauline Blackpool. That's now going to be your name. As long as I haven't got to say the organisation, I can stick to Pauline Blackpool, I'm happy. So again, what was the most important learning that you took away?
Yeah, so Blackpool's kind of been on a 4-year journey around thinking about the Born into Care data and recommendations. We're one of the pilot sites. It's been my absolute privilege to be part of that 4-year journey. And I think it's so difficult to kind of just pick one. But I think for me, this is about a really, it might sound really obvious, but not starting with assumptions. So I think what I've really learned is that when you're thinking about service and systems transformation, people come into it with the assumption that they understand what the problem is. And actually really getting under the skin of the problem needs a whole range of experts around it. So that's families, that's, you know, practitioners, so midwives, social workers, academics, senior leaders, commissioners, you know, really getting under the skin of the problem and understanding it from, you know, with a real depth, because that's the place to start and then move on and start thinking about kind of solutions.
Yeah, absolutely. We can't solve the problem if we don't
Unless we
actually
know what it
identify
is.
what the problem is. And like you say,
Yeah.
that assumption. And I think as parents ourselves, we've all been in that situation where a practitioner has assumed they know what we need or assumed that they know what the problem is. And we're sat there thinking, well, actually, if you just ask us,
Yeah.
we could actually tell you and be able to work together to find a solution. That's brilliant. Thank you so much. I'm going to come to Kate now and our wonderful Giving Hope project. So again, what's been the most important learning for you when we were initially setting this up, which seems like forever ago?
It does, doesn't it? Thanks, Angela. So just to say that Birth Companions have been working since 2019 with this project team working together. We began working as part of the Born into Care series with Claire Mason at Lancaster University, and this therapeutic offer grew from it and blossomed and started its own life, and Birth Companions are very proud to still be supporting and part of it. What we learn is that we have to listen. We listen to women with experiences of the system, with those lived experiences. We centre them, we support them, and we work together as a team to for our mission, which is that this therapeutic offer of the Hope Boxes is available to all women who are going through such a traumatic situation, and they need compassion, they need support. And so our vision is to make sure these boxes, with all the thought put behind them, created every step of the way by women with lived experience. The need is there. We listen to the women, we listen to the amazing Hope mothers, and we move forward and we ensure that all women have access to this support.
Absolutely, yeah. So all women and babies deserve hope, and they deserve a story, even if it's a traumatic story. It needs to be done with love and kindness and compassion. And I'm going to slightly flip my question to Pauline and Brooklyn, because I think of all the learning that's been done, you've been on the other side of it. I think you've been doing the teaching. So I think but what have you yourselves, and I'll come to Pauline Hope first, about what have you learned? Because I know myself being involved in it, I've learned lots of things from the professionals, the practitioners that I've worked with, and the training that we've designed. So what would you say you have learned from this, or what have you taken from the Giving Hope?
I think for me, as a birth mother going through separation, the one thing that I realised is how much the Hope Boxes are needed. And that is obviously a very happy, sad experience, because when you're going through a removal, you don't realise at the time who else is going through it. You think you're the only one and that you're alone. But to realise that they needed up and down the country, not just in my own area, they needed absolutely everywhere. But it also helped me realise the importance of coming together as mothers to know that we're not alone anymore, and to support each other and give each other understanding.
Every time I look at you. Oh no. Well, Brooklyn, it's your turn to follow Pauline. It was Pauline's turn to follow you before. Are you okay? Do you feel able to follow that?
I'm
But
good.
I know from you, what has been your learning? What have you taken away from just being part of such an amazing project and journey?
So I think what I take away from being a part of Giving Hope is that actually there is, I can see one, I think there's two women, actually both women that were here when my daughter was separated from me. And although I didn't have the Hope Box at the time, a lot of what they gave inspired my work, my reasoning to wanting to come and be a part of the Hope Project. Because none of you can be my bigger critic than I can be of myself. So when I am being fed externally and internally by, being a bad mother, and as some of those things that we saw in one of the reports, an addict, domestic violence, and all the rest of it, very much seeing that it looked like it was just me, and being able to come and be a part of this has been able to see that actually, it's not just me. And although, the feelings can be really intense and can be really strong, one of the things that has been built outside of just the boxes themselves is a family. It's like, you almost probably would have heard the proverb of, it takes a village to raise a child. And I think these boxes and the training behind the boxes give everybody that, because it's not just about giving a box to the mum and to the baby. This box is a pathway for everybody to be involved in that baby and mum's life, and to limit the amount of trauma that comes from all of them.
Absolutely, and I think for me, we've spoken so much today about labels that we've been given and labels we didn't want, and this is probably the bit where my voice is going to go, but for me, being a Hope Mum is a label I'm incredibly proud of, and I think we've been able to stick that over all of the other horrible labels and actually have a label that we can stand tall and proud about and say we've helped people and we are continuing to help people. So thank you both. I realised I've left my watch over here, my time over here, and wondering about all over the place. That's fine, we're fine, we're all good. So I'm going to go in the same order again, and I want to ask, what do you offer that you think makes a difference to women and babies? So Phoebe, I'm going to come to you first.
So I don't work on the Project Unity service. We've got 9 project workers working across all 22 local authorities in Wales, which I think is just amazing. We've got such a small team doing such great work, and I think the best thing that the service offers to these young women is just someone to be on their side. All of our project workers, advocates, and particularly for care experienced young women, we find that when they're going through these proceedings and with multi-agency, their voices just become lost, their rights become lost, and our project workers, they're there for the women. They advocate for them, they empower them so they can advocate for themselves, they know their rights, they know their entitlements, and just having someone there who is on their team going, actually, I believe in you, you can do this, and installing that belief and trust into them. It's been said so many times today about making sure that women with lived experience, when they are involved in this, it's listening to them, but just going beyond that and actually valuing what they're saying, taking it and going, yeah, you should be here. And yeah, I think our project work that's the part that really stands out. It's that relationship they build with the young women and then giving them the tools to empower them and have a voice in a system which often doesn't hear their voices.
Absolutely, that power of that one person, and they're being victim to a system that almost separated them from any support and then judged them for not having support. So that we all know ourselves, the power of that one person, just believing that you're capable can make a huge difference. So thank you so much. I'm going to come across to Kay with the same question. So what difference do you think it's making to the mothers and babies?
So we're really at the beginning of our project, but I think one of the things from the professionals who've been involved with all the community services, women with lived experience that have helped us kind of shape our work, is about seeing the mum. And with all these services that focus on babies and children, and especially midwifery service and so on that will follow baby, it's about seeing mum and dad and partners and what support they need. I think it's about really, it's been mentioned a few times, but bringing reunification kind of back as a really leading point, that actually that's what we should be aiming for, even in proceedings where we're kind of feeling like maybe we're not seeing the changes that we want. How are we going to get to a point where we can do that? And then I think it's trying to put really practical things in place for social workers and midwives when they're kind of on the ground doing it. So it's things like trying to we're currently negotiating with the hospital for confidential spaces so mums can attend court virtually at hospital rather than having to leave their baby there. We're also trying to negotiate with them to let mums and babies stay in for 5 days rather than trying to have that court hearing as early as possible. Practical things like the breast pump loan service, so just getting people talking to mums when we're looking at removal about breastfeeding. I think sometimes professionals are scared of talking about what we see as normal mum things when we're in a process of removal. So breastfeeding is still possible, but how are professionals practically going to do that? Where's the guidance? Where's the tools on the ground for kind of doing that with mums? And getting people to talk about that choice. So like the Born Into Care series, we're really trying to put in the recommendations of talking about it as early as possible, talking about the positive choices that mum can have, and then what can we do to implement it, and have it as a plan that follows them, that goes to all professionals, so they don't have to tell people more than once. Everybody's got it, everybody knows kind of what their wishes are, what are some of the choices that they've made, and how can we support them in doing it.
Brilliant. So it's that transparency so that mum knows exactly what's going to happen and when, and isn't sort of just completely blindsided and then is left traumatised trying to argue. I mean, fits in perfectly with everything that we stand for at Giving Hope. It's seeing that separation is just that first step and it's not the last step. And I think if we constantly keep looking at that and everyone's focused on, okay, maybe we've had to remove baby, but what do we do now to make sure baby can go home? And that, you know, that staying in hospital for a little bit longer where there's no risk to baby, but services don't support it. So having someone alongside mum who's advocating for that is just giving them the best chance, and that's all we've ever asked, isn't it? A fair fight and the best chance possible. So that's brilliant. Thank you so much. Now, Pauline Blackpool, and that's going to be your name for today. We're going to change.
This is the fact that we've worked really hard with our HR department at Blackpool Council to create employment roles which are specifically for it's for people, but in this case for parents with lived experience to be employed as co-production sessional workers, engagement workers. So, you know, navigating that whole job evaluation process where we can get a really decent pay for people, even though there's no formal need for qualifications. So the only essential criteria being lived experience. So we've worked really hard to do that. And what we've seen is that that's made a massive difference to like the power dynamic when we're doing co-production projects. So everybody else is paid to be in that space. Why shouldn't parents be paid to be in that space? And even if and even if parents don't feel ready to step into formal employment, then there's, you know, kind of voluntary positions as well, so parents can feel like they can grow into that. So we feel that's, you know, that's that kind of real, this is a social justice, you know, I really feel like this is a social justice issue as well as a moral issue for the way that we go about, you know, creating co-production opportunities for families. And what we've seen is that, you know, we've heard so much this morning, haven't we, about parents and families feeling so othered, not feeling, but being othered by the system. And that actually being part of co-production, what parents are telling us is that they've kind of moved from feeling othered to feeling like what they do really matters, you know, kind of think about that, you know, how important that is for all of us as human beings to feel like what we do matters. So having those employment opportunities, meaning that families are routinely in co-production spaces. It's created a culture in the council where we've even got the chief exec now talking about the importance of, you know, having lived and living experience in our transformation work. And, you know, our director of children's services, Lisa's here with me. You know, she's regularly having discussions with our DCS about things that need to happen. So it's just it's a real mechanism creating that culture as well.
It's the true example of working together, isn't it? And there's that saying of nothing about us without us. And I think that's what you're saying there. And that it's very easy to say you value someone, but then, as you say, not paying them or not actually putting in steps that need so that they can actually participate. So it is about really valuing the expertise and seeing it as that, as expertise rather than just something that someone has suffered. It's we've learnt lessons along the way that were hard won, and having the opportunity to use them it is incredibly empowering. So I'm going to come to Kate with the same question, and I think I was slightly easier to. What difference do we think that we're making to mothers and babies with our amazing Giving Hope?
Yeah, thanks, Angela. It's actually quite a hard question to answer because I think that every day we are finding more and more what the boxes are doing, how they're reaching people. As we're developing the boxes, we're working with different groups of people to develop them, we are just seeing that there is more impact and more impact. I think it helps everyone. It helps the mum, it helps the baby, it helps the professional in that situation. It gives the professional a focus and some way of working, supporting the woman and turning this situation, bringing compassion to this situation, bringing compassion to those kind of early hours and days when baby's been born. So I think it helps everybody in this situation, and it is about hope, obviously, massively about hope. It's about connection. It's about not losing sight of that if a separation happens, this is, at that moment, this is a temporary thing. So it has to be about maintaining that connection with all of the different items. I'm not going to go into any more because some of the mothers might be going into that, but it's about so much, and it has the power to really heal. And I think just my last point is about women not feeling alone. We talk about this so much, about how isolating that situation is, and is this just happening to me? And I think that by writing the letter in the box and by reaching out to these women that are getting the boxes, we're able to say, you're not alone, and to create that kind of unity and support. It's a way of reaching out to all these women that are going through an unimaginable time, and them knowing that we're all working together to try and make this better and to try and do things to support them.
Yeah, absolutely. And I think that's one thing that we didn't mention about the Hope boxes is they're not compulsory. We don't expect any mother to take them. We send a letter from us that says, these boxes are here, these are who we are, why we designed them, and we'd love you to have one, because we know women in that situation have very little choice and control, and part of it was trying to give them something that actually they had a say in and they were part of. So I'm going to come to my last two. Pauline Hope, again, that's now going to be your name from now on, and then Brooklyn, if you want to come in afterwards. So what do you think the difference is, and what do you feel the difference is, obviously having lived this yourself?
When I was planning to answer this, it was a very difficult one to answer, because the Hope boxes make a real difference in many different ways. But one important thing for me would be keeping connection after separation and helping the mother to still feel like a mother. For me, it would have helped me to continue breastfeeding and helped me to express milk. This was the one way that made me still feel like a mother, but it was also my way of my baby still having a piece of me with her when we weren't together. But it's not just about keeping connection between mother and baby, it's about keeping connection between mother and professional. Helping the mother to possibly see the professional in a different way, and to remind the professional that this is still a mum that is losing her baby, and to help her show compassion and understanding. And this may just help the mother to realise that the professional is not the enemy, and therefore help to build a positive relationship and some trust. And for the third one, it also helps the connection between mother, baby and foster carer. it was essential for me to have a positive, trusting relationship with my baby's foster carer, so that I knew that my baby was in safe hands and looked after and even loved. But it was important so that I knew that she did everything she possibly could to keep the connection between me and my baby and include me in every aspect of my baby's day-to-day life, which also helps you to feel like a mother, and that just reduces the stigma, reduces the trauma, and the mother feels every day that they are a part.
Thank you, Karen.
I think for me, the one thing about that the hope boxes do is they have an ability to stop the me versus you. Because like Angela said, they're not compulsory, because in a lot of the childcare process, mothers or parents in general, we are told we have to. And in this case, it's a case of actually, here, you can have it, you don't have to have it. And it's designed so beautifully that it's not a one-time offer. There is a pathway along that mum and child's pathway when that box can be offered all the way through. And it builds relationships, not just between the mum, the baby, but as Pauline said, the professionals, the foster carers, and it kind of makes sure that everybody is on the same page. Because one thing that the hope boxes do is that they capture their moments that even if reunification is possible, you can't give me back the moment my child first smiled, the first time it said a first word, or the first time it got its hair cut. And ultimately, if the baby goes on for adoption, that's birth certificate of what I named my child. You can't give me that back. And it provides space for also to do life story work. Because I think in a lot of that, what is lost sometimes is nobody thinks about life story work, not just for the baby, but for the mum. How is the mum supposed to, whether she goes on to have, reoccurrent pregnancies and reoccurrent care proceedings, how does she make sense of that? And how does she make the changes that the professionals want her to make if she has no understanding of actually what I've done potentially wrong, and where I can fix up on it. And I just think, all in all, I think actually all of the programs on here are absolutely amazing, inspiring, and changing, doing things that need to be done.
Absolutely. And I think for me as well, that the Hope Boxes is about that baby's story and that baby's right to know their story, their right to know they were loved, their right to know who they were named after, who they get their hair from, all of those things that we look at a system through the lens of risk. And we're not actually looking at it through, every child's birth should be a joyful occasion and should be recorded as that. And I think when we're looking at separation, we forget that and we take out all of the love and the niceness, and we just make it clinical. And actually what the Hope Boxes do is they put the love and compassion back into that moment, and we give women, and there's the quote from one of the mums, it may have been you, Brooklyn, which is, walking out of hospital with empty arms and an empty belly. We can't do anything about the empty belly, but we can make sure they haven't got empty arms. And so for us, that's a fundamental part of giving hope. It was just also to let you all know there are Hope Boxes here if you would like to have a look at them, if you want to speak to any of us about what's in the box and why it's in the box and why we chose it, that would be brilliant. I realise we're slightly over time. I don't know how we're doing for questions, and what I don't want to do is just send you all off for lunch and realise that there was a list of people sitting waiting with questions that we haven't answered. But I'm being told time's up. I'm being told so that the decision has been taken out of my hands. You're all way too hungry, but I'm going to come back round because I realise I keep neglecting everybody that's been online. And what I wanted to say to those online is thank you so much for joining us. I do hope that you felt included and part of today. It's been quite difficult, the layout of the room and hiding behind pillars, but today isn't just about having one conversation and then everything ending. So to those of you online, please do reach out to us, get in contact, read the research, see how you can get involved in our projects, and really keep the conversation going, because we want today to be a catalyst for further change, not just the end of the discussion about the change that's happened so far. So to everybody online, thank you. I hope you all have a lovely lunch. And to those of you who are in the room, we are going to release you into the room with the lovely lunch, and we're going to see everybody. Now, we're going to see. I'm going to tell you a time to come back. So wait, I'm not going to release you until I know what time I have to bring you back.
1:45.
1:45. I'd like you all back in the room because we're going to see a production, and I know you're all going to be keen to see it. So thank you all very much.